Every peak and valley on an electrocardiogram corresponds to a specific electrical impulse triggering a muscle contraction within the heart. Standardizing your analysis with a 10-step checklist provides a reliable framework to process these waveforms and identify underlying cardiac pathologies. Before applying the steps, there is one absolute prerequisite for interpretation. You must understand that the horizontal axis of standard ECG paper strictly represents time. Look at this grid. The fundamental unit of measurement is a single tiny square. Exactly one small square equals 0.04 seconds. The entire interpretation relies on this constant. Without correctly applying this 0.04 second measurement, calculating heart rates or identifying fatal irregularities is impossible. Step 1 is determining the rhythm. For atrial rhythm, measure the intervals between consecutive P waves. To find the ventricular rhythm, measure the distance between two consecutive R waves. Step 2 determines the rate. This graphic details the 10 times method. Obtain a 6-second strip, count the R waves, and multiply by 10. For higher precision, use the 1500 method right. Count small squares between consecutive R waves and divide 1500 by that exact number. These calculations set your physiological boundaries. A rate falling below 60 beats per minute indicates bradycardia, while a rate rising above 100 signifies tachycardia. Establishing this baseline rate and rhythm dictates your entire context. It reveals whether the heart is in a sustainable state or facing an immediate crisis. Steps 3 and 4 focus on the atria. Confirm a P wave precedes every QRS complex. Then measure the PR interval by counting the small squares from the start of the P wave to the start of the QRS complex. A normal PR interval duration is 0.12 to 0.20 seconds. Falling within this specific normal window confirms the impulse is following standard conduction pathways, resulting in a healthy sinus rhythm. Step 5 evaluates the heart's electrical axis. This chart maps the electrical charge direction. A normal axis is between -30 and +90 degrees. Deviating into other zones indicates severe pathologies. Right ventricular hypertrophy pulls the charge into the right axis deviation zone. An abnormal axis serves as a direct indicator showing exactly which side of the heart is failing under pressure. Next, conduct a rapid assessment of the ventricular waves, combining steps 6, 8, and 9. Verify the QRS complex width is a normal 0.06 to 0.10 seconds. Ensure T waves share the QRS deflection, and measure the QT interval. When checking that QT interval, precision matters. You must measure exactly to the point where the T wave fully returns to the baseline, not just its peak. Step 7 evaluates the ST segment. This image shows the contrast between normal and pathological findings. Upsloping can be a normal variant, but horizontal or downsloping ST depressions indicate myocardial ischemia. Step 10 involves scanning for ectopic beats and evaluating ST elevations. This chart breaks down how specific leads act as a targeted map, pinpointing exactly which vessel is blocked during a myocardial infarction. Completing these final steps allows you to identify active physical tissue death in real time. Looking at this physical ECG strip, you can see how all 10 distinct steps merge to form a single comprehensive diagnostic report. Adhering to this sequence consistently eliminates clinical guesswork. It ensures that hidden anomalies are caught before they turn lethal. To build your own expertise, download practice rhythm strips, use physical calipers, and apply this checklist until the measurements become second nature. Applying this system turns raw electrical data into an actionable clinical assessment, providing a direct view of a patient's cardiac health.